Hi everyone! Blood flow restriction is the topic that Emily and I decided to cover for our presentation today, so I hope you enjoy. Okay, so here's an outline of what we're going to go over today in our presentation. We're going to talk about the guidelines for using blood flow restriction bands with exercise, the scientific theories behind the effects of blood flow restriction, when to use it, when not to use it, adverse effects, some case studies, and then we'll review and go over a summary. How to use blood flow restriction bands. Blood flow restriction is a training method partially restricting arterial inflow and fully restricting venous outflow in working musculature during exercise. When the cuff is inflated, there is a gradual mechanical compression of the vasculature underneath the cuff. The amount of pressure required to cease blood flow to a limb is related to various individual limb characteristics: tourniquet shape, width and length, the size of the limb, or an individual's blood pressure. A bigger limb will require greater cuff pressure to fully restrict arterial blood flow, and this is true across a range of cuff widths. It is recommended to set the pressure during blood flow restriction exercise based on the measurement of AOP and using a percentage of that pressure during exercise, generally ranging from 40 to 80%. Cuff size determines pressure as well. A wider cuff requires a lower pressure due to the greater surface area in which it is applied. Here is a chart of the guidelines for blood flow restriction. We'll have this on the handout that we provide for you guys, so you'll be able to look at it more in depth. But for frequency, it's about 2 to 3 times a week or 1 to 2 times per day. It's a 20 to 40% 1 rep max load. And then for the repetitions pressure, it's 75 reps, and usually the first rep is 30, and then the following 3 sets are only 15 reps to get 75 total. Where to wrap? Here's some do's and don'ts on applying the wrap to a patient. We do want to keep the wrap at the top of the arm or leg only, and you can wrap your arms or shoulder or chest for workouts or your legs for glutes. Just use your head and keep the weights light. And we don't want to wrap at the knee or calf training or at the elbow for forearms. We want to wrap high on the leg or arm. And wrap for any lift above 50% of your 1 rep max. 20 to 40% is the sweet spot that we want to get with these patients. How to wrap? We do want to use a narrow cuff or bandage to reduce the risk of occluding the arteries with patients, and we want to wrap in layers, and it's likely to use an ACE bandage, narrow tourniquets, or knee wraps. We don't want to use a really wide blood pressure cuff for this and wrap in a spiral fashion covering a large amount of the limb. How tight to wrap? We want to aim for about a 6 to 7 tightness on a scale of 10 total. We want the patient to feel okay leaning towards the side of a little too loose rather than too tight. 40 and 80% of occlusion have shown the same level of muscle and strength gains. Keep this in mind when working with our patients. We don't want to wrap to the point where you feel numbness or tingling in the limb. Don't wrap so tight that you have trouble performing more than a few reps. High reps are the norm for blood flow restriction.
Here are some scientific theories behind the effects of blood flow restriction. Increased circulating hormone, specifically growth hormone, recruitment of fast twitch muscle fibers through creating an anaerobic environment, and increased metabolic response. Growth hormone and testosterone are believed to be influential in eliciting training effects causing hypertrophy and muscle repair. In one article I looked at, it assessed growth hormone, testosterone, and lactate in 3 groups, which was one with low resistance, blood flow restriction without exercise, and then moderate resistance without blood flow restriction. The results showed that lactate response was not significantly different between the low resistance blood flow restriction and the moderate resistance. And growth hormone levels were significantly increased in the low resistance blood flow restriction group compared to the moderate resistance group. And then testosterone levels did not change significantly between the groups. Here's a chart showing the growth hormone differences between the three groups. And you can clearly see that the low resistance with blood flow restriction significantly outweighed the other groups, including the moderate resistance without the blood flow restriction. And growth hormone has thought to be known to not rise appreciable levels unless you're doing moderate to high resistance loads. So the article states that it's thought that it could be a result of the ischemic environment contributing to this increased hypertrophy from the growth hormone. The second theory is fast twitch muscle fiber recruitment. So we know that fast twitch fibers are recruited after slow twitch fibers with increasing resistive force and are responsible for hypertrophy. So several studies have suggested that blood flow restriction causes early recruitment of fast twitch fibers due to inadequate oxygen supply to slow twitch fibers. In an article I found, it showed that increased fast twitch fiber recruitment via phosphate splitting was in 31% of people after low resistance blood flow restriction exercise and in 0% of people after low resistance alone. However, it did show to be in 70% of people after moderate intensity exercise alone. So this just kind of shows that the moderate intensity would still have greater fast twitch fiber recruitment, but adding the blood flow restriction significantly increases the recruitment compared to low resistance exercising alone. All right, and the last theory is blood flow restriction effects on metabolites. So, blood flow restriction causes an increase in metabolites from decreased removal through the veins and the hypoxic environment. Depletion of phosphocreatine, increase in organic phosphate, decrease in pH, and lactate accumulation have all been suggested to be strong stimuli for inducing training effects. In an article that I looked at, it showed that with low resistance and blood flow restriction, there was greater depletion of phosphocreatine, increased organic phosphate, and decreased pH compared to low resistance without blood flow restriction. Also, these metabolic responses showed to be almost equal of that with moderate resistance exercise alone.
So, when would we use blood flow restriction? To accelerate strength gains in older individuals that can't handle high loads of resistance, post-op patients that have weight restrictions, people with arthritis or other degenerative diseases to protect their joints from heavy loading, and recovering athletes starting on a low resistance training program, such as an ACL rehabilitation. As you can see, there's a variety of patients that we can use this with, as long as it's safe. So when would we not want to use blood flow restriction? We wouldn't want to use it on people with a deep vein thrombosis or at high risk for one. We wouldn't use it on anyone that's pregnant or people with varicose veins or other venous diseases. People with high blood pressure or heart disease, we want to be cautious when using this. Some adverse effects of blood flow restriction that you want to warn your patients about are dizziness, fainting, numbness, pain, delayed onset muscle soreness, bruising, and swelling.
So I looked at an article that was comparing ACL recovery with and without the use of blood flow restriction, and it looked at 44 patients that were randomly divided into two groups, and they used the same rehabilitation plan consisting of low intensity and primarily closed chain exercises. One group used blood flow restriction and the other did not. The results were that the evaluations of the knee extensor and flexor torques before surgery and 16 weeks after showed significant increase in muscular strength in the blood flow restriction group compared to the other group. And the preoperative over 16-week postoperative ratio of cross-sectional area of the knee extensor muscles showed statistically significant enlargement in the blood flow restriction group compared to the other group. And then 16 weeks after surgery, the short diameters of type 1 and type 2 fibers of vastus lateralis tended to be larger in the blood flow restriction group compared to the other group as well.
This study looked at the blood flow restriction during high-intensity cycling in athletes. 20 trained males with the average age of 26 were randomly divided into a program of sprint cycling with or without blood flow restriction. It was a 4-week program of 4 to 7 intervals of 30-second max sprint. The blood flow restriction group was set at 130 millimeters per mercury during the first 2 minutes of a 4-minute rest period and without blood flow restriction for the control group. The absolute and relative VO2 max increased 4.5% in the blood flow restriction group versus 0.7% in the non-blood flow restriction group. Increased absolute and relative mean aerobic power and peak power output in blood flow restriction group. This study looks at the effects of walk training with leg blood flow restriction in elderly adults. This kind of shows that you can use it on a variety of types of patients, as our last study looked at high-intensity athletes, and now we're looking at elderly adults. In this specific study, 23 adults, ages ranging from 66 to 68, were randomly assigned to a control walk training group or a blood flow restriction walking group. They had 20 minutes of treadmill walking at an exercise intensity of 45% of heart rate reserve, 4 days a week for 10 weeks. The blood flow restriction walking group wore blood pressure cuffs on both legs during training. The maximum knee joint strength increased 15%, and an MRI measured thigh muscle cross-sectional area 3% increased in the blood flow restriction walking group, but not in the control group. The carotid arterial compliance improved 50% in the blood flow restriction walking group. Walk training with blood flow reduction can improve thigh muscle size and strength, as well as carotid arterial compliance, unlike high-intensity training in the elderly.
All right, so here's a summary of what we talked about today. So the physiological sequences that cause these results are not fully understood. However, there are many theories. The low intensity exercise at 20 to 30% 1 RM plus blood flow restriction causes gains in strength and hypertrophy greater than low intensity exercise alone, and similar to moderate to high intensity adaptations. Blood flow restriction causes blood pooling and a hypoxic environment, resulting in increased type 2 fiber recruitment, increased growth hormone, increased metabolites, and increased myogenic stem cell proliferation, which all potentially contribute to strength gains. Strength gains seen with low resistance blood flow restriction exercise do not seem to surpass the strength gains of moderate to high intensity exercise in many studies. However, the results are very close, if not equal, making it a good alternative. And there is evidence to show that blood flow restriction exercise can cause increased training effects in aerobic exercise as well, such as walking and cycling in young adults and elderly. All right, and here's our references. I hope you guys enjoyed the presentation. If you have any questions, feel free to email us.